Professor Tarek Abdel Hadi Ali available? Ah, Dr. Tarek Ali, I can see you in the screen. I hope you'll be able to unmute yourself, because it would appear that I'm going to be calling upon you to do your next presentation now, for which I'm most grateful. Are you able to unmute yourself?
Now it's okay, it's clear? My voice is clear?
Yes, absolutely. Thank you so much.
And I shared the screen. Is the presentation clear?
The presentation's not on the screen yet. It looks like it's going to be appearing any second now. It's in the right-hand corner at the top.
Yes, exactly.
This happened yesterday, didn't it?
Yeah, this is my university, the logo of Cairo University. Is it clear?
It isn't clear. It can hardly be seen. It's in the literally the top right-hand side of the screen.
Yes. So now
are you able to? It is clear now. Thank you.
Clear now.
Thank you so
first
much.
of all, this is the sample image of the beauty of Egypt. I can't. So. First of all, I would like to thank again. I was here yesterday in my presentation of the neuroendocrine tumors, and I'm again with you today in another presentation. It's also on a rare entity. I always like the rare medical problems since I was a young medical student. Anyway, first of all, I like to thank the organizing committee of the UCG for inviting me to share my knowledge and art of practice medicine with my colleagues and the attendees. I'm Professor Tarek Ali. I'm a medical expert, a senior consultant physician, and formerly professor of internal medicine at Cairo University. This is the logo of my Cairo University. It's a time-honored old university in the Middle East, very famous. This is the logo of Cairo University. This is the topic of my presentation today, is the endocrine involvement in systemic amyloidosis, complicating familial Mediterranean fever. And in fact, I'm going to present a case report, which was published in Cairo University Medical Journal and in the Egyptian Medical Syndicate Annals of Medicine in 2002 and 2003. First of all, I like to, I have disclosure that my presentation has no commercial background. This is very important to declare, and I have no financial conflicts of interest to declare also in my presentation. I will be discussing purely science and art of familial Mediterranean fever and its complications, focusing on the endocrine involvement, because my special interest in internal medicine is in the subspecialty of endocrinology. That's why yesterday I presented the endocrine manifestations of neuroendocrine tumors, and today I'm going to present the endocrine involvement also in familial Mediterranean fever. Familial Mediterranean fever in general is a rare disease and is a rare cause of acute and recurrent fever. And in particularly also its complications, and especially the endocrine complications, is rare. So it is rare of the rare. I will speak about rare of the rare. Rare presentation, which is endocrine involvement of a rare disease, which is a familial Mediterranean fever. The outline of my presentation will be, is my voice clear? Everything's clear? That's Dr. Telly. Yeah, I see your beautiful finger from South Africa. Yeah. How are you doing? Right. So the outline of my presentation will be definition and prevalence of familial Mediterranean fever, and the Aetopathogenesis and pathobiology of familial Mediterranean fever, the clinical spectrum and diagnosis of familial Mediterranean fever, complications of familial Mediterranean fever, pathobiology of systemic amyloidosis, complicating FMF, I will abbreviate as FMF, this familial Mediterranean fever, although sometimes we call it familial inflammatory polyserositis, and this is the more modern name, familial inflammatory polyserositis, or the classic name is in the clinical literature is FMF, or familial Mediterranean fever. Endocrine involvement in systemic amyloidosis, endocrine sequelae of FMF, and impact of complications on the natural history of and the course of familial Mediterranean fever, and then I will come to summary and conclude. Fine. We all know that familial Mediterranean fever is an hereditary disease. It is an autosomal recessive autoinflammatory disease, which is characterized by acute and recurrent fevers. So it is a rather chronic disease presenting with acute symptoms and having a chronic course, and might present with, as I mentioned, with acute on chronic. So it is among the acute, it is among the chronic, it is among the acute on chronic diseases. So it is rather a chronic disease. And by the way, familial Mediterranean fever is not curable. It is a non-curable disease, but it is it can be put under control. So it is controllable. So it is a controllable disease, but not curable disease. Just like diabetes. Diabetes and hypertension, they are not curable, except, of course, the secondary forms of hypertension, if it is due to a tumor, or secondary diabetes, if it is due to an underlying cause, we can treat it. But the usual classic diabetic syndrome, type 2 and type 1, they are non-curable diseases. They are controllable diseases. Same in hypertension also, same in many types of epilepsy, same in many chronic medical disorders. Same applies here in our chronic fever, this illness which I'm talking about. It's a chronic fever. Actually, it is a chronic disease with a hereditary background, which might be modulated by environmental factors. And it is characterized by inflammation. So the most notable pathologic feature of this fever is that it is an autoinflammatory disease. It is a chronic autoinflammatory disease with acute inflammatory exacerbations. That's the acute exacerbations which we are seeing clinically. It is due to acute exacerbation of the underlying chronic inflammation. It is one of the clinical causes of fever of unknown origin. That's whenever we meet a case of fever which is not responding to treatment, for example, for more than 3 weeks, or it is recurrent, so we should suspect the familial Mediterranean fever, especially if this fever is associated with the clinical features which I will mention later on. That's the pains, acute pains affecting the abdomen and the chest. So, plus or minus the joints, of course, as I will mention. So it is an inflammatory familial polyserositis. Pathologically, the term polyserositis describes where is the inflammation is, in which parts of the body the inflammation is concentrated or is focused. It is in the serous membranes. That's why we call it inflammatory polyserositis. It affects multiple serous membranes. It affects the peritoneum. It affects the pleural membrane in the chest of the lungs. It affects the pericardium surrounding the heart. It affects the synovial membranes surrounding the joints. It affects the tunica vaginalis surrounding the testes. So it affects actually all the serous membranes mostly, but the inflammation can involve other tissues of the body, including the skin, including the subcutaneous tissue, including the muscles, including the blood vessels. So it is a widespread inflammation, but mostly focusing in the serous membranes. Familial Mediterranean fever has been well identified in the last 5 decades. Of course, it has been described since a long time, since the beginning of the last century, but it has been more well identified in the last 5 decades. As we say, it's a chronic systemic inflammatory disease with acute exacerbations and periodic course. That's why we have to differentiate this chronic recurrent fever from other causes, which I will mention, other causes of fever with body pains, or with abdominal pain and chest pain, which as the main features, like the hyperimmunoglobulin D syndrome with periodic fever. This is another disease, and from also another disease which is called the familial Hibernian fever. Familial Hibernian fever is another disease. Also, hyperimmunoglobulin D syndrome with periodic fever, or hyperimmunoglobulin D with periodic fever syndrome is another disease. So these three diseases should be differentiated from each other. The hyperimmunoglobulin D with periodic fever syndrome, the familial Hibernian syndrome or Hibernian fever, and the familial Mediterranean fever, another entity. These are three different chronic fevers or clinical entities which might present with fever associated with pains in the body, in the abdomen, in the chest, in the joints, etc. So it is an inflammatory disease. This inflammatory disease is associated with rise in the acute phase reactants, which is characteristic, and it might be complicated by systemic amyloidosis, and this is the main danger, with its multi-systemic sequelae, which might complicate the course of the familial Mediterranean fever. And here comes the danger of the familial Mediterranean fever. The familial Mediterranean fever is a disease which might be complicated by secondary amyloidosis. And this amyloidosis, as we know, is a systemic disease which involves the different organs of the body, and which might at the end cause organ failure, especially the kidney, and it might end with renal failure, because the amyloid infiltrates the kidney and causes a nephrotic syndrome, and the nephrotic syndrome will end in end-stage renal disease and renal failure. Also, the amyloid might infiltrate other organs in the body. It might infiltrate the liver, it might infiltrate the spleen, it might infiltrate the endocrine organs and endocrine glands, like the pituitary gland in the brain, the base of the brain. It might infiltrate the thyroid, it might infiltrate the adrenals, it might infiltrate the parathyroids, it might infiltrate all or any endocrine tissue in the body. It might also affect the ovaries and in the ladies and cause infertility. That's why 1/3 of patients, ladies with or women with familial Mediterranean fever, have infertility, and this is another danger. So whether it is infertility, whether it is renal failure, whether it is endocrine syndrome, all are related to the amyloidosis as a complication of the familial Mediterranean fever. That's why we have to put the familial Mediterranean fever, we have to diagnose it early, and we have to put it under control in order to prevent or at least minimize the severity and delay the onset of amyloid disease and its complications. Gene mutations play a role. Actually, familial Mediterranean fever, it is a clinical diagnosis which might be supported by genetic testing, but genetic testing does not exclude the diagnosis, or cannot exclude the diagnosis of familial Mediterranean fever if it is not supportive, if it is not diagnostic. But if it is positive, as it is known about the genetic background of the familial Mediterranean fever being a hereditary disease, autosomal recessive disease, as I mentioned, so it will be supporting the clinical features or the clinical presentation, and it will help us to say that this is sure 100% a case of familial Mediterranean fever. Not, as I mentioned, the other causes which I mentioned, then the Hibernian syndrome or the Hibernian fever or the hyperimmunoglobulin D with periodic fever syndrome or other causes. So the genetic understanding of the familial Mediterranean fever is important, but again, I repeat again, it is a clinical diagnosis which might be supported by a genetic, positive genetic testing. What is the genetic background of the, why we say the gene or genetic study or genetic background, and you will find in the literature too much information about the genetic background of because it develops in certain patients who have mutations affecting a certain gene, which is located on the short arm of chromosome 16 in the cells, which is called the MEFV. MEFV gene is the most important gene responsible for its mutation will cause or will aid in the pathogenesis of or clinical expression of the familial Mediterranean fever. The MEFV, and MEV means ME from Mediterranean and FV from fever, MEFV. So this MEFV gene is the one which is, if having mutation, it will cause the clinical expression of familial Mediterranean fever. And in order to be expressed clinically, the condition should be inherited as an autosomal recessive disease. We all know that autosomal recessive means that 2 copies of the abnormal gene should be inherited from the 2 parents. 2 copies of the abnormal gene. We can't inherit. If it is 1 copy only inherited and it causes this is autosomal dominant. But in autosomal recessive, the 2 copies of abnormal gene should be inherited from parents to children. And this is the case in our familial Mediterranean fever. Familial Mediterranean fever is an example of an autosomal recessive disease. And this genetic mutation is common in people of Mediterranean origin. That's why Mediterranean origin descent or Mediterranean origin ancestry, that's why we find this disease more common in the Mediterranean basin, in countries of the Mediterranean basin who are fighting together now. Turkey, Egypt, France, Greece, Italy, Israel, Armenia. That's why we'll find that it is more common in Armenian people, in Jewish people, Sephardic Jewish and Ashkenazic Jewish and Arabs and North Africa and the European countries on the Mediterranean, which I mentioned them, Greece, Italy, France. So cases are concentrated here. But if you find, what about its prevalence or its epidemiology worldwide? You can find the cases of familial Mediterranean fever in the USA or in Germany who are away from the Mediterranean basin. How? By the immigrants. So it's important to ask about the ethnicity of the patient. So ethnic background is very important. And family history are very important in the diagnosis. One of the pivotal important points to diagnose family is to ask the patient, is there a family history in your families? Do you have brothers? Do you have sisters? Do you have cousins who are having, or your father or your mother, who are having the disease? He will tell you, yes, I have my father, I have my mother, I have my sister, I have my brother having this. We are 3-4 members in the family having the same problem. So family history is important. Especially that I mentioned that it's an autosomal recessive disease, whether it is heterozygote or homozygotes. So family history important and ethnic background is very important. Where are you from? Which ethnicity are you from? Are you Jewish? Are you Arab? Are you coming from Turkey? Are you coming from Greece? Are you coming from, this will be, and it will help you to diagnose the case, to spot the case, to pick up the case that this fever, which is recurrent, coming from north coast of Egypt, or the Turkey Mediterranean coast, or Aegean coast, or from Greece. So, and this patient and her family. So this is sure clinically it is familial Mediterranean fever, even before we proceed to genetic testing of the case. Anyway, again, I say that it is gene important, family history important, ethnicity important. It is autosomal recessive. It is the most common monogenic autoinflammatory. It's another fact that it is the most common monogenic autoinflammatory disease. It is related only to one gene, which is it is not polygenic. It is, as I mentioned, related to the MEFV1. Although maybe they have described, and there is no consensus about the issue of familial Mediterranean fever genetics, or the genetic identification or genetic characterization of the familial Mediterranean fever, especially that they found and they reported that other gene mutations might play also, or might be involved in familial Mediterranean fever. That's why that is
Genes other than the FV might be involved. Not only this gene, there might be involved, because they described cases which are exactly similar. It is a familial mediator with negative EFV gene mutation. So this means, or this raises the possibility that might be other gene mutations responsible or play a role in the etiopathogenesis of this chronic autoinflammatory febrile illness. Yes, more than 310 MEFV sequence variants have been identified. Oh my God, this is too much. But not all of them are responsible for the disease actually. And what's meant by that MEFV sequence variants? That it is the commonest site actually is 694, the M694V, that is the replacement of the methionine with valine. So that's methionine is amino acid, valine is amino acid. So it depends on the sequence of amino acids on that gene, and which amino acid is replacing which amino acid, it will characterize the variant. So you have to understand the biochemistry of the gene. You have to understand the sequence of arrangement of amino acids in order to understand when we remove. If any one amino acid replaced by another amino acid, it will cause a disease. Oh my God. And this shows the greatness of God in our bodies, the miracles in our bodies. Or one amino acid can change the whole life of the patient. An example here, it is sequence of MEFV sequence of amino acids producing different variants which can cause a disease or not cause a disease. Not only this, it has been linked also, the variants linked to who will develop a mild disease and who will develop a more severe disease, and who will have propensity to get complications and who will not get complications. So actually the genetic background help you predict the clinical phenotype and the gene, and also the possibility of the complications, and how will the natural history of the disease will be in that particular case. So how is the natural history? How is the presentation? Is it mild case or severe case? When does it present? Will it present in childhood or in young adolescence or in late adulthood? This is related to the which variant of gene mutation is there in the patient. And is it will it be a mild disease with very infrequent exacerbations, with long periods of symptom-free intervals or periods, or it will be a very devastating disease with too much exacerbations and very short symptom-free periods of disease? This is related to genetic background. So not all variants are associated with the disease phenotype as a called variants of uncertain significance. The role of genetics in familiarity is screening the most common mutations. This is very important. We have to screen for the most common mutations. We have to screen for the most common mutations. Actually, I want to say this is very important. The latest is here. In 2012, a group of clinical and molecular experts, they gathered to put a consensus to test for a total of 14 MEFV variants, including 9 clearly pathologic variants and 5 unknown variants. In the Eastern Mediterranean, the genetic distribution is rather similar. Also, there is a difference between the Eastern and the Western Mediterranean and the North African. The genetic distribution and which variants are more common in this area in comparison to the others. Let me go first to my, and then I will come back again to the genetic background and this, to my case report. We, in our case, it was a 43-year-old male patient who was admitted to our medical unit from the OPD with recurrent, I just want to get this screen here.
in order to be able to remember the case. It's a long time. So 43-year-old male patient was admitted to our medical unit from OPD with recurrent fever for several years, weight loss over the last few years, recurrent constipations for 2 years, hair loss over the past several months, and neck swelling for the last 3 years, anterior neck swelling. The patient came from the north coastal Egyptian town and had a family history of similar recurrent febrile episodes in one of his brothers and a sister. The exact underlying cause and nature could not be clearly elucidated for several years. They remained undiagnosed, for nobody diagnosed them for several years. Our patient was once appendectomised before for an acute right lower abdominal pain during one of his febrile episodes 6 years back. Thorough clinical evaluation of our patient paid our attention to possible FMF being the etiology of his chronic medical problem, especially that he had recurrent fevers and the disease ran a chronic insidious course with exacerbations, and he had, with the fever, acute abdominal pains in most of the attacks, and sometimes also acute chest pain, acute anterior chest pain, sometimes right side, sometimes left sided, and this goes with the possibility of pleurisy, acute pleuritis, and clinically manifest chemical peritonitis that's presenting with abdominal pain. It is not, of course, not septic peritonitis. It is a sort of inflammatory peritonitis due to the familial Mediterranean fever. And then we started to do, after we traced the family, we found that he had a family, this is very important, and also coming from a north coastal town. So the origin, the place of his birth and stay was in the Mediterranean and on the north coast of Egypt. And the family, he has family, so there are two important points in his history which might point to the possibility of familial Mediterranean fever. And then we started to do genetic counseling also and investigations. We investigated the patient. We sent him to the Genetic Research Institute in Cairo and we asked our molecular geneticists to help us in the diagnosis of and the genetic evaluation of these cases. And we found that he had evidence of suggestive of the MEFV mutation in this particular case. We began detailed evaluation of the case and his affected family members and genetic counseling and investigations done for them, which confirmed FMF diagnosis with high certainty. Especially that I mentioned that it is a clinical diagnosis and the genetic testing only might support but does not exclude. Biochemical and hormonal assays also showed evidence of impaired kidney function test profile. There was evidence of proteinuria, massive proteinuria, which supported the diagnosis of nephrotic syndrome also. And when we biopsied the thyroid gland, this after being radiographed by sonography, of course, ultrasonography of the thyroid proved diffuse swelling of the gland, and then we did fine needle aspiration biopsy, and it proved that there was an amyloid infiltrations, but it didn't reveal malignant or any suspicious thyroid pathology apart from the amyloid. Surgical consultation also done and excision biopsy done of the thyroid, actually because the thyroid also was a little bit embarrassing for the patient, causing obstructive symptoms for him. So we did partial thyroidectomy, and this excision biopsy also, this was more confirmative than the aspiration cytology, which was done earlier. And we found islets of amyloid infiltrates in the thyroid. Renal biopsy also, of course, advised, especially that the patient presented with nephrotic syndrome, evidence of nephrotic syndrome. We all know that nephrotic syndrome, it is a clinical pathologic diagnosis characterized by massive proteinuria, hypoalbuminemia, and edema. And the three features were in that case. So also renal biopsy done and revealed evidence of amyloid kidney. The differential diagnosis didn't refer to any underlying neoplastic etiology, but referred to the possibility of complicated chronic case of familial inflammatory polycirrhosis. And of course, also we did serum amyloid, and we found positive serum amyloid with what we call reactant serum amyloid in his blood. Also, the renal biopsy was positive for amyloid when we did the immunohistochemical studies for that for these biopsies from the thyroid and from the kidney. And this proved that and confirmed that the kidney is one of the target organs of amyloid infiltration complicating familial Mediterranean fever. And we should always do a renal biopsy in such case, especially if the patient has a sort of glomerulopathy, whether it is clinically manifest glomerulopathy. Of course, most commonly as nephrotic syndrome. It is not nephritic, it is not nephrotic. And even if the case is subclinical, that is not clinically manifest, but it might be pathologically, the kidneys might still be pathologically involved. The absence of clinical features of renal disease does not exclude amyloid pathologic involvement of the kidney. And still we have to do renal biopsy to confirm the presence of glomerulopathy and amyloid infiltration. Detailed imaging of his neck, chest, and abdomen and pelvis using ultrasound, CT, and MRI scans did not show any further etiologic lesions. The patient was put under regular intermittent colchicine therapy with thyroid replacement therapy and other dietary and medical advice to control his complications, to control the kidney problem, special management of the nephrotic syndrome, of course. We have to manage the case as a nephrotic. We have to manage the case as a thyroid, especially that the patient also went into hypothyroidism related to the original infiltration of the thyroid by the amyloid and became more exaggerated by the thyroidectomy, which is done. So it's both by the pathology and by the surgery. There was a residual hypothyroidism, and the patient was under clinical, medical, pathologic, and radiologic follow-up and showed smooth, stable clinical course in his OPD regular visits with no further deterioration over several months. This was the ultrasonography of the thyroid, shows here evidence of thyroid enlargement, diffuse thyroid enlargement, which points to the possibility of a diffuse, because actually the amyloid, when it infiltrates the endocrine glands, it will cause rather diffuse infiltration. There is no nodulation or no, there might be in some cases nodules, but in most of the cases diffuse infiltration rather than localized infiltration or nodular pathology, although it might be associated with nodules. This was the right thyroid sonography. Here is the, it's clear the infiltration, the amyloid infiltrates in the thyroid biopsy. This is the excision biopsy after being thyroidectomized. This is also the renal. This is the renal biopsy in that case. Here we see the infiltration of the amyloid infiltration in the glomeruli. It is usually in the endothelial side of the glomerular-based membrane and also in the glomerular blood vessels. The amyloid infiltrates will be clear in the glomerular vessels and in the basement membrane. As we see in this case, the amyloid staining is very clear. Here we come back to our case report. We should be aware of these points: the typical versus the atypical cases, the complete versus the incomplete attacks of the. It is what we call typical familial Mediterranean versus atypical familial. For example, among the atypical is the atypical presentation. Most of the cases of familial Mediterranean fever are diagnosed early, that is in childhood or in adolescence. It is rare to be before 20 years of age. And some of the cases are even diagnosed before 6 years of age. So can it be diagnosed before? Yes. That's why it is a point of interest among the pediatricians, the general pediatricians or the pediatric rheumatologists, because they see such cases of familial Mediterranean fever associated with joint problems, as I will mention. So it might be atypical in presentation, atypical in age of onset, atypical in the clinical presentation, atypical in the fever, atypical in the severity of and the frequency of the attacks, atypical in the course of the disease, the natural history of the disease. How will the disease progress? Atypical in the onset of complications. When will the patient get complications? So it is not only related to whether the patient started treatment or didn't start treatment. It is related to the genetics of the patient, the gene background of the patient, who will say whether he will have a mild course or a severe course, typical or atypical. And of course, comes after that the treatment. The more the delay in the start of or the initiation of giving the patient treatment, initiation of therapy, the more will be the severity, and the more faster will be the complications of the disease, including the amyloidosis, including the endocrine problems, including its complications in ladies and infertility, including the complications in the joints, the arthropathies, and other complications. The genetic testing is mandatory. There were some systems adopted by some medical authorities or organizations, like the Livni et al. System in diagnosis of Mediterranean fever. As I mentioned, if FMF may be misdiagnosed as infections, cholecystitis, acute appendicitis, acute arthritic syndromes, other forms of autoinflammatory diseases, and other cause of fever of unknown origin. This should always be considered in the differentials. When we meet a case of familial Mediterranean fever, we should think of these possibilities, because for example, in our current, let us come to the real world, to the issue of our COVID-19. Now we are living in these crazy times of the COVID now. How can we diagnose, for example, a case of familial Mediterranean fever in the COVID era? Anyone who has fever in our time is COVID until proved otherwise, right or wrong? Anyone who has fever, now the people, if you meet anyone in the airport, I was just trapped in Japan for 3 months, by the way, lockdown, and I just came back to UAE before more than 1.5 months. And I gave them a lecture while I was in my hotel at that time, that not every case of fever is COVID, as if all the other viruses have disappeared from this world, and all the viruses mentioned in the textbook of virology and microbiology, they are not there anymore, and it is only the coronavirus. No, of course we should not, the corona should not make us as scientists, as senior doctors, as people who have knowledge, not public people. There are other causes of fever. There are other causes of fever. There are not only other causes of fever, there are other infectious agents which might cause fever. There are many other viruses. There are many bacteria. There are many fungi. There are many parasites. There are other non-infectious causes of fever. Malignancies, endocrine causes, metabolic diseases, collagen vascular diseases, autoimmune diseases, all these might cause fever, apart from infections. And in infections, multiple infectious etiologies. Among them is viruses, and in the viruses, many viral groups, not only the corona. So why are only focusing on the corona as the main cause of fever, as if we have only this corona in our world, we and the corona? It is, of course, a sort of human stupidity, I consider it. Sorry to say this. But anyway, I come back to infections. Cholecystitis. Many cases of familial Mediterranean fever are wrongly diagnosed as appendicitis, and they are appendicectomized because they just presented with abdominal pain and they were not thoroughly evaluated, history, physical examination, and these things. And then the doctor referred him to the surgeon, and the surgeon, after putting him under observation some time, decided to open the abdomen and remove the appendix. And this is not a case of straightforward appendicitis, it is a familial Mediterranean fever, presenting with acute lower abdominal pain due to the peritoneal inflammation. That's all. It is a chemical, it's an inflammatory peritonitis, and not related to infections. It's an autoimmune. It is not infectious inflammation. It is an autoimmune inflammation of the peritoneum, causing a picture similar to appendicitis. So Many are wrongly diagnosed as appendicitis. Many are wrongly diagnosed as acute cholecystitis. So what can make the physician, the smart physician, think about or have what we call high index of clinical suspicion and think that this might be a case of FMF is the presence of fever. So fever and serous inflammation and picture of peritonitis, especially also if of abdominal pain associated with chest pain. So if fever, some will say, Dr. Tarek, no, that it might be obstructive appendicitis. Some case of infectious obstructive appendicitis might have abdominal pain and the fever. Yes, right. But the pattern of fever here is different, and the family history is different, and the background is different, and the other systemic features are different. So it's not as straightforward of infectious appendicitis. It is rather an autoimmune appendicitis or autoimmune peritonitis due to familial Mediterranean fever. And the clinician has to revise his diagnosis. So this is in the differentials. Also, it should be differentiated from other causes of arthritis, especially that some cases, especially children, might present with fever and acute arthritis or chronic arthritis, because these patients might get acute joint pain affecting especially the joints of the lower limbs, especially the knees and ankles, and sometimes the hips, and sometimes in the upper limbs, the elbows. These are the joints most commonly affected. That's why any child, for example, presenting with fever and joint pain, we should think of FMF also as a possibility. And in many cases of familial Mediterranean fever, in the chronic course, they go into or they proceed into what we call chronic arthropathy. This chronic arthropathy, it might simulate the seronegative, what we call seronegative spondyloarthropathies. So the seronegative spondyloarthropathies, that's the ankylosing spondylitis and the Reiter syndrome and the psoriatic arthropathies, they enter into the differential diagnosis of chronic familial Mediterranean fever. This is to complicate more the clinical course and the clinical picture. Is it for FMF or is it chronic seronegative spondyloarthropathy, especially in the chronic case I'm speaking? And here the pathology of the chronic arthropathy with FMF is different from the endocrine involvement, which I have mentioned in my case report, and different from the renal involvement also, which I described in my case report, which are directly due to the amyloid disease. In arthropathies, other features share in the pathogenesis of the chronic arthritis. Same also, sorry, next. So these are I mentioned Dr. Telia, how long still I have in order to not run out of time? 10 minutes, 5 minutes? Tongue.
15 minutes, Prof. Tarek.
20 minutes?
15.
15 minutes. Okay. That's fantastic. Fantastic. Thank you so much, Telia. So again, I come back quickly to this issue that the danger of, or the problem of the familial Mediterranean fever is in its complications. That's why we have to diagnose it early. We have to diagnose it early before it develops complications. We have to diagnose early in order to start the treatment early. And luckily enough, we have now many treatments. I will mention them just after a few minutes. The complications, they are common in the untreated cases and the cases with certain genetic features, especially with delayed or improper diagnosis. That's why we have to diagnose the case early and confirm the diagnosis of FMF early and start treatment early. Because if there is no proper diagnosis, no proper treatment. This is a rule in medicine. We have to diagnose right in order to give the right treatment. If we are diagnosing wrong, so everything after that is wrong. End-stage renal disease due to systemic amyloidosis, secondary amyloidosis, malabsorption, etc., endocrine involvement, and this was the focus of my case. But my case that focused on the thyroid involvement as a model of endocrine involvement complicating systemic amyloidosis in patients with familial Mediterranean fever. But the patients also, in other cases, you might find infertility. 1/3 of female patients with familial Mediterranean, of course, familial Mediterranean fever affects both males and females, although it is rather a little bit more common in males in comparison to females. Or if compared to females, it is 1.8 to 1.2. And it can affect, it starts in childhood, as I mentioned, but it can be diagnosed even as late as 30s. We can diagnose new cases, especially the homozygous case and the autosomal dominant cases. We have found some cases, and in some gene mutations, we found some cases which present late, not present early as the classic autosomal recessive affecting the MEFV1 gene, which I mentioned it, and according to, of course, certain gene mutations. I don't have time now to explain how the gene mutations and their diversity can affect the clinical, but I just give you an information that they determine the clinical course and the liability and the propensity to complications in every individual case. His gene expression phenotype or his gene expression profile. Infertility is a common complication. Not only this is it's a common complication. I want to spot the light on an important fact. Some acute cases, especially males, they might present, in addition to the fever, abdominal pain, chest pain, joint pain, they might get testicular pain. And you will find that in the literature, some male patients with familial Mediterranean fever may get swollen tender scrotum, although it is rather rare. So even in a case of fever with scrotal pain, you should suspect familial Mediterranean fever. See how medicine is very, very wide? You should maybe familial Mediterranean fever, because it affects the inflammation, the autoinflammatory process affects the tunica vaginalis testis. So when it affects the tunica vaginalis, it will present with scrotal pain. It's not a localized disease. It might be misdiagnosed as torsion of the testis or orchitis or other causes of scrotal pain. But it might be a systemic cause involving the scrotum, the testis, inside the scrotum, so presented with a scrotal problem. Scrotal enlargement, scrotal swelling, which is tender and painful. It is FMF. So this FMF in a male, scrotal pain. FMF in a female, oophritis, proceeding to female infertility. And even if the female gets pregnant, and this sometimes happens if her fertility, if by chance she got pregnant, she will get fetal loss. So even fetal losses are more common in familial Mediterranean ladies, who are pregnant ladies. So the relation of FMF to the sexuality, the relation of FMF to gonadal function is also documented. It is not only localized to the abdomen, to the chest, to the also to the gonads and sexuality and the sexual function of the individual. If it affected the pituitary gland and since childhood, as I mentioned, it might cause growth. It might be one of the causes of growth retardation in children. So the child, in his investigation, one of the important fevers causing growth retardation is familial Mediterranean fever. So these are all complications. Factors predispose to complications: genetic mutation, as I mentioned, age of onset, duration of the disease, ethnic and racial background, whether homozygous or heterozygous, when we study the case genetically. Also, early diagnosis versus late diagnosis, and early versus late initiation of colchicine therapy, because colchicine is a pivotal primary treatment. In addition to the more modern treatments now, we have now biologic therapy for familial Mediterranean fever in the last 5 years. Anti-interleukin 1 beta and interleukin 1 monoclonal antibodies, and also tumor necrosis factor blockers. These are new medications, biologics in the treatment of which are developed over the past 5 years, which are used as a second-line therapy after colchicine in FMF to minimize the symptoms, to decrease the retard the exacerbations, to prolong the symptom-free periods of the patient, and to delay or minimize, if not preventing, the complications of FMF, including the endocrine complications. This is the importance of starting colchicine and the biologics early in the course of treatment. Endocrine involvement FMF, it's any endocrine organ can be involved in febrile illnesses, both directly by the infectious agent or indirectly through toxic substances or amyloid disease, as in our case, the FMF. Endocrine involvement can be seen in both acute and chronic febrile disorders, and hormonal assays should be done. Part of the investigations, you should assay the thyroid function, you should assess the adrenal function, you should assess the pituitary function, because it might cause hypopituitarism, it might cause hypoadrenalism, it might cause hypothyroidism. Even before causing the hypothyroidism, if it presented with thyroid swelling, that's adrenal, that's endocrine organ, the most notable is thyroid swelling, we should assess the case, and even if the gland is athyroid, we should be careful about that. It might also still, there is still evidence of involvement without dysfunction. That's still, there is no hypofunction, but there is amyloid infiltration.
Professor Ali, I'm
Yes.
so sorry to interrupt,
Yeah.
but we are running now short on time.
Okay,
Can you close down the presentation? I'm so sorry about the misinformation you had.
no, it's okay now. It's okay. It's the summary and the conclusion already came to the last slide now. This in my presentation. So this is the recently an international expert group has published the new recommendations for familial inflammatory cholestasis management and approach. Colchicine remains the mainstay of FMF treatment. Colchicine prevents or decreases the long-term risk of amyloidosis and endocrinopathies. The minority of FMF are non-responders or intolerant to colchicine, and this should have special approach. Biologics, as I mentioned, also could be a breakthrough in FMF treatment and preventing or minimizing complications. Non-compliance to colchicine may be an important issue in those patients. These big points. Thank you so much for your listening and for your patience and tolerance, and I appreciate it. Thank you.
Thank you so much, Professor Ali. That was